vision therapy. And I hope everyone is really good and doing well. Without further delay, I would like to have this opportunity to inaugurate this session. But before that, I want to request you all to make sure that your audio is muted until and unless you have the queries to speak up or any information to share with the group. And please feel free to come up with your queries and ideas to make the session more interactive. Today we will be having our 16th session on approach to NSBVD by our faculty, Mr. Hiranath Dahal. I welcome you, Hira sir, for today's session on the behalf of Mero Eye Foundation and all our participants. Over to you, sir.
Thank you, Solu, for so nice introduction. So yeah, welcome everybody after festival break. So today we are going to have a discussion, let's say a more discussion on how to make an approach, how to manage the different aspect of non-strabismic binocular vision disorders or dysfunctions. So a quick summary about the previous session. So first we went on to the different diagnostic part, the sensory part, the binocular part, and the accommodative test. We discussed all those aspects, and then how these the findings of all the tests that we perform to make are grouped into different, like as we discussed in our previous sessions, the positive fusional vergence group, the negative fusional vergence group, and the accommodative group, how all these data are collaborated and how we come to a concrete diagnosis of different types of syndromes that we have in non-strabismic binocular vision dysfunctions. Okay, so today we'll go a more detail into that. And so again, overview of management is that we discussed first corrections of emmetropia is very much important. So one thing again, today also a bit the sessions, I expect the sessions to be interactive because there is much discussions part in these sessions also. So so my request to all the members here or the participants here to be much interactive in the upcoming slides. So as we know, the overview of management is the first, the if the corrections of significant amount of emmetropia, and to see whether the added lenses power is required or not, and horizontal prism. And of course, the vision therapy is the mainstay, is also a mainstay of treatment in non-strabismic binocular vision dysfunctions. Okay, so a bit about optical corrections. As we know, binocular balancing very much important, and in added lens power, the ACY ratio plays a very much important role in whether added lens power is required for the patient or not. And of course, the horizontal prisms, there are some conditions in which a prism plays a very important role. And of course, the final mainstay of treatment is the VT. Okay. So now today also we have many cases to discuss. So I'm just checking the chat bottom, so so that we could get an uh, answer or response from the participants. So let's see. Okay, so I have a case. A 21-year-old man presents with a complaint of intermittent diplopia that is bothersome when he looks at distance, and the problem has been presented for several years, and the refraction on refraction is finding is both eye plus 0.5 diopter, and distance foria is 10 iso, and the near foria is ortho. Okay, the patient has orthophoria at near, and the calculated ACY ratio is 2:1. So what would be first, I know everybody could come up with a diagnosis. So what is the diagnosis of what is the diagnosis of the, what is a preliminary diagnosis or provisional diagnosis of the patient? Okay, so anybody could share what would be the diagnosis of the patient, and then what would be the management plan? Okay, so what would be the management plan in this particular cases? So can anybody share? Or I'm also actively seeing the chat button, so anybody could share the discussion about these cases. Okay, so what is the main key points here to see is intermittent diplopia at distance, and the distance foria is greater than that of near foria, and of course the ACY ratio is low. Okay, yeah, the cases is this is a case of divergence insufficiency. So what my concern here is, so what would be the refractive corrections? Okay, so as we can see, the patient has 0.5 diopter objective refraction. So would you prescribe or not? Okay, so would you make a prescription of a glasses alone or not? That is the main concern that I am going to share with you. Yeah, of course it is a case of divergent insufficiency. I see participants sharing their answer. So now my next concern is, what about the refractive corrections? Okay, would you incorporate these amount of refractive corrections or not while prescribing to the patient? So what would be the initial approach? Okay, so yeah, I can see one answer that no correction, no corrections. Any other person can share their views regarding how to make an initial approach in these cases. Yeah, what is the point is, yeah, actually plus 0.5 diopter is not a significant refractive corrections. So prescribing this refractive error in this case would have actually no. What is our main concern is to change the phoric status of the patients and to make the patient more comfortable. Okay, because the patient is not able to diverge for distance, especially for distance, so he is having intermittent diplopia at distance. So our main concern here is to eliminate a diplopia at distance. So how that can be done? That can be done by decreasing the usual deviation at distance. Okay, so these refractive corrections or the prescribing these refractive error would have no effect, because plus 0.5 would as we know that the ACY ratio is low, so prescribing this refractive error has no effect on reducing this, especially the distance foria. Okay, so if we prescribe plus 0.5 according to ACY ratio, the distance for foria would come to 9. Okay, so 10 to 9, so no significance. So also because the ACY ratio is low, and we cannot opt for an added lenses for distance only, so our refractive corrections is not significant here. I can see answers here. Okay, so basically divergence, this is a case of divergence insufficiency. We'll get into more depth about how to manage divergent insufficiency, but what I'm going to share in this slide actually is, so if the refractive corrections is there, it's not that we should prescribe it, rather we should make an critical analysis to make the patient more comfortable on his symptoms. Okay, regarding the decision to manage the diabetes disease, I'll come in the later slides. I have something to share. Okay, so now next case again. A 14-year-old girl presents with the complaints of eye strain, blurred vision, and watery eyes after 10 minutes of reading. Okay, so the near point of convergence is 20 centimeter, and ortho at distance, and exo at near. Okay, and the subjective finding is -2 diopter ODOS. Okay, in both eyes subjective refraction is -2 diopter. Okay, and ACY ratio. So what do you feel? Would the prescription of these refractive error? Okay, so I guess most of all know the diagnosis itself by seeing the phoric status. Okay, it is a case of convergent insufficiency itself. Okay, so what I'm trying to convey a message among all of us is that apart from refractive status, also the non-strabismic by presence of different types of dysfunctions, binocular vision dysfunctions plays a very much important role in deciding the subjective refraction. Okay, so what I'm trying to share is that presence of non-strabismic binocular vision dysfunctions change our approach to manage a patient with only refractive corrections. Okay, so if for example uh, actually this is a child wearing this subjective refraction. Okay, so our main concern is whether the patient will benefit from the added lenses or not. First, I'm just going to talk about added lenses. Okay, since the ACY ratio is low, the added lenses would not be of much help. Okay, we have to go for another approach like using prisms or VT as an mainstay treatment for the patient with these kind of problems. So for low ACY ratio, okay, these were the two cases with low ACY ratio. Okay, so the low ACY ratio mostly consists of two cases, like that is convergent insufficiency and divergent insufficiency. So what about the optical corrections? What is the thing to consider in optical corrections in patient with low ACY ratio is, in low ACY ratio cases, although the lens has little effect on size of the deviations, presence of refractive error may create an imbalance between the two eyes. Okay, so this imbalance may lead to sensory fusion disturbance and create a decreased fusional ability due to blurred retinal images. Okay, so for patient, added lenses would not, the mainstay is added lenses would not be of much help. So either prism or VT should be considered. So for the patient with convergent insufficiency, so what is a point or clinical pause while making a decision in prescribing? Okay, so as a general rule, convergent insufficiency is generally associated with more than zero point 0.5 diopter of anisometry. If convergent insufficiency is associated with more than zero point 0.5 diopter of anisometry, a refractive correction should be prescribed. If convergent insufficiency is associated with myopia, okay, small myopia, 0.5, the myopia, in that case, the myopia could be secondary to convergent insufficiency, because if the patient has convergent insufficiency, the patient of course will have some accommodative excess. Okay, so if the patient has convergent insufficiency, we have to check the accommodative status. If the accommodation is, the patient has excess accommodative tendency, then it could be associated with, it can manifest with small amount of myopia. So in that case, after all detailed evaluation, we can do a cycloplegic refraction to help in determining whether then accommodative issues is there or not. Okay, so if the myopia is secondary to binocular vision problem, then prescribing a minus lens would not help the patient, and in that cases, vision therapy should be performed, or the patient should be treated with different approaches, and the refractive errors should be monitored. Okay, again, I'm just going to repeat that. If convergent insufficiency is associated with milder degree of myopia, and that CI may could have resulted to myopia itself. So in that cases, a complete evaluation should be done, and if possible, if the cycloplegic refraction showed no any significant refractive error, or the reduced myopia, or the patient comes to becomes emmetropic on cycloplegic refraction, then we will come to an idea that myopia was due to the binocular vision problem, that is CI, and the prescription of minus lenses, it's of no use in many of the cases. So in that cases, for complete management of the patient, vision therapy should be performed and refractive errors should be monitored. So with moderate degree to high degree of myopia, prescription is indicated. Okay, sometimes basically I don't know in other scenario, but what I see is in Nepalese scenario is that basically most of the people who are engaged in optical part, okay, so the patient will come with the headache or mild astronopic complaint, and we see the prescription of minus 0.25 or minus zero point 0.5 lenses is very much higher, especially in the optical outlet. I can say that in the context of Nepal, but I don't know in other scenario what is that. Okay, so what is a take is actually it would not help the patient. Some placebo effect would be there with the prescription of glasses, that the patient might feel, okay, I'm wearing the glasses, so I have been treated, so my problem should be little less, but actually the we have to go for complete evaluation to find out whether the that myopia, smaller degree of myopia in the stenopic patient could be because of all these non-strabismus binocular vision problem. Is there underlying binocular vision problem or not? That should be ruled out first, and then the corrections, if required, can be provided. Okay, so the approach would be different in the different aspect of myopia. But if the patient has a high degree of myopia, prescription is indicated. Okay, so this is some concept on convergent insufficiency. So regarding divergent insufficiency, the presence, if the, with a divergent insufficiency, the presence of hyperopia or anisometropia is significant. If the patient has significant amount of hyperopia, a prescription is um, a prescription should be done. Okay, so when considering the final prescriptions of this patient, it is important to first determine whether the vertical deviation is present. Okay, so divergent insufficiency is sometimes associated with vertical deviation, so we have to check whether there is vertical deviation before making the final prescriptions. So what is a difference between managing aspect of convergent insufficiency and divergent insufficiency is that they're different. The main difference is that effectiveness of horizontal prism. Okay, so in divergent insufficiency, the base out prism, the prism would help the patient to relieve their symptoms very fast. In case of divergent insufficiency, but with prism, I'm talking about prism. Okay, the difference between the management of convergent insufficiency and divergent insufficiency, especially with the prisms. So divergent insufficiency patient would be very much symptomatically better with the prescription of prism itself, but in convergent insufficiency, prism is much helpful, especially for adult population, but in children it has been found to be relatively less useful. Okay, again, if a child has a convergent insufficiency, a basin prism is found to be relatively less useful in children, but it has been found to be much helpful. Horizontal prism, especially basin relieving prism, has been found to be much helpful, especially in adult population. Okay, so there has been one randomized trial. Okay, why the basin prism is not considered in children is that there was a randomized trial done. A paper was published entitled as randomized clinical trial of the effectiveness of basin prism reading glasses versus placebo reading glasses for symptomatic convergent insufficiency in children. Okay, so it was actually a randomized clinical trial. So as we all know that randomized clinical trial provides highest level of evidence. So what was done was in the randomized clinical trial, 72 children aged 9 to 18 years, less than 18 years, with symptomatically CI were assigned to either basin prism or placebo reading glasses, and symptom level was measured with CISS, convergent insufficiency symptom survey. That these symptoms was the primary outcome, and the secondary outcome was considered near point of convergence and positive fusional convergence at a near were considered the secondary prism secondary outcome. So what was the result was actually the mean convergent insufficiency symptom survey was decreased in both the groups. Okay, so in basin prism glasses group, 31.6 to 10.4, 31.6 to 16.5, and in placebo glass group 28.4 to 17.5. So actually the symptoms decrease in both the group, and the change in convergent insufficiency symptom survey, even NPC, even positive fusional versions group were not significantly different between the two groups after 6 weeks of wearing glasses. Okay, again, the CISS score, the near point of convergence, and positive fusional versions, there was not somewhat significant changes was found in the symptomatic status of the patient as well as other signs in the patient with children with convergent insufficiency. So basin prism glasses was found to be more effective in alleviating symptoms, but it was not statistically significant. So if a children is considered, we can consider a basin prism, but vision therapy is the mainstay of treatment. But in adult, uh, because this was a randomized clinical trial performed in children, there is no such trial performed in adult population. So adult population could be helped with the prism, but in children, a basin prism is relatively less considered, because what is the main issues is the issues is a prism adaptation. Okay, the children will eat up the prism, will put a basin prism, and the patient will be adapted to that amount of prism. And again, in a long run, we have to increase that amount of prism. Rather, the patient, we have the child will starts eating the prism. The prism adaptation goes on, and that cycle continues. So basically, rather than basin prism, vision therapy is the mainstay of treatment for CI. Okay, so again, vision therapy the primary of treatment options for convergent insufficiency, but vision therapy is challenging with a divergent insufficiency. Okay, because the improvement of basically in divergent insufficiency, our mainstay of therapy is to improve fusional versions at distance, and it is one of the most difficult goals to accomplish with vision therapy. So what are the things that we do? We'll talk in the upcoming sessions. Okay, so divergent insufficiency cases mostly treated with the prism, and also VT is also a stay of treatment for them. So again, coming to VT aspect, some VT aspect. Okay, again, treatment of CI. The basin randomized clinical trial was performed, and this found the basin prism would decrease the symptoms, but it was same, not significantly different, and it was same as the placebo classes. So vision therapy is the mainstay of treatment for convergent insufficiency. So again, a randomized clinical trial was performed for treatment of convergent insufficiency in children, and these found that, okay, so office-based vision therapy. Okay, office-based the so what was this study about is that in a randomized multicentral, it was a multicentral clinical trial. 47 children, 9 to 18 years of age, with symptomatically CI were randomly assigned to receive 12 weeks of office-based vision therapy or vision therapy, and office-based placebo therapy, and home-based pencil push-up therapy. So three group of therapy were compared to treat a convergent insufficiency: office-based VT and office-based placebo VT, which would not include accommodative inversions. Other thing would be included, and the third category is home-based pencil push-up therapy. Though, so these three treatment were um, uh, uh, compared. Okay, this was a, actually we can find this full publication in the internet itself. So this was published in 2005. Before that 2005, before this randomized clinical trial was performed, the pencil push-up was the mainstay of treatment. Especially when the orthoptic model of treatment was mainly used for convergent insufficiency. So a randomized clinical trial was performed, and the result of this trial was symptoms which were similar in all groups at baseline were significantly reduced in VT orthoptic group. Okay, so on performing vision therapy, the symptoms could be significantly reduced. The from 3.21 to 9.5, the symptoms was reduced, but not in pencil push-ups. Okay, in pencil push-up, they don't found a significant decrease in symptoms of the patient. Okay, and this concluded that vision therapy, office-based vision therapy, especially office-based vision therapy, was more effective than pencil push-up or office-based placebo therapy in reducing symptoms and improving signs of convergent insufficiency in children. So this is a evidence for the usefulness of vision therapy for the treatment of convergent insufficiency, especially in children, also in adults. So these were the different phase. We will discuss these all in the upcoming lectures. So phase one, they what did they work is they work on gross convergence, positive fusional versions, and monoclonal accommodative therapy, and then they increases the range of fusional versions and monoclonal accommodative therapy, and in the third phase of jump versions and binocular accommodative therapy. So these all therapy procedures will discuss in upcoming therapy discussions part. Each aspect of this therapy will discuss. So what today we are going is we are going for general overview of management of these kind of conditions. Okay, so now actually there was a discussion in the previous session itself, the condition called pseudo convergent insufficiency. Sometimes we are the convergent insufficiency and could be associated with accommodation insufficiency also. So in that case, it is very necessary to differentiate a convergent insufficiency and accommodation insufficiency. So, what is a pseudo convergent insufficiency? Is that it is a condition in which primary problem is accommodative insufficiency, and because of that accommodative convergence, because the patient has very decreased accommodative insufficiency, they are not able to stimulate their accommodations, and because they are not able to stimulate accommodations, the accommodative convergence will be poor. So the amplitude of accommodations and all other test ability, assessing the ability to stimulate accommodations are especially reduced in these cases, because the patient tend to accommodate as little as possible on any given demand. As a result, accommodative convergence is reduced, placing a greater demand on positive fusional versions. And if a patient is again exophoric, the additional demand leads to the patient to converge insufficiency. Okay, so in the if as in the diagnostic part, I discussed that we have a discussions regarding whether to how to differentiate a convergent insufficiency and pseudo convergent insufficiency. So repetition of near point of convergence, small plus lens for near. Okay, so if the patient has improved uh, near point of convergence with the idea with the placement of plus lens in front of them, if that improves the near point of convergence, we can come to a diagnosis of pseudo convergence insufficiency. So with plus lens, what happens is the patient may accommodate it more accurately, leading to improvement in near point of convergence. Okay, so I have a case to share. Okay, so pseudo CI cases. Okay, so a 15-year-old child complaining of eye strain and blurred vision, again the astronomic symptoms, regular patient, and this was the findings actually 1 year back. This was a finding, and 1 year back the NPC was 10 centimeter, amplitude of accommodation 15 diopter, ortho small exo again, and ACY ratio normal, base out value. These were the value. Okay, so now the patient again came with a issue. The child came with the issues of eye strain and blurred vision at near. So these were the findings. The near point of convergence was 20 centimeter, amplitude of accommodations 16 diopter, distance Fourier ortho was there, and there was small increase in exophoria, and calculated ACY ratio was actually reduced. Okay, so versus facility, the slow with base out, and again base out value was also low. But what we can see is the NRA value is okay here. Okay, so this is NRA is a indirect test of positive fusional versions. We can see that NRA value is okay, but the PRA value is less. Okay, so again in binocular accommodative facility, the patient fails minus. If the patient is a case with convergent insufficiency, they would fail plus. Okay, and MEM was lag. So in that case, so if we see straight, okay, if we have just a direct view of, if we think straight, the let's see the Fourier ortho distance near exo. Okay, so it directs us to a case of convergence, and again we see a near point of convergence, and also is it resident, also the base out value is poor. Okay, so we may come to a case that we may come to a concept that okay, it would be a case of convergence insufficiency, but the thing is that on testing PRA, the patient's is the PRA value is low. Okay, on checking relative versions with constant accommodation, the PRA value is low. Again, in binocular accommodative facility, the patient is failing minus, and MEM is lag. Okay, so especially if it would be a case of convergent insufficiency. The case the if the convergence insufficiency would be there, the patient would have increased accommodative response for a given stimulus. Okay, so sometimes thinking straight also won't work. Okay, again NPC, Fourier, and base out value would lead us to a diagnosis of convergent insufficiency. But in this case, what we need to see is, let's check our amplitude of accommodations also. Okay, so what is the average amplitude of accommodations at this age? We know that there is a Hofstadter formula, 18 minus a is by 3, 18 minus 15 by 3. Okay, 15 by 3, 5. So 13 diopter is the uh, 13 diopter is the amplitude of accommodation, as this is. So because the amplitude of accommodation is severely reduced, the patient is not able to converse. Okay, the patient is not able to converse. Also, in these cases, what is a diagnostic test that we can perform is checking a near point of convergence with small amount of plus lens would give us the idea about what is the conditioning going here. Also, in the binocular accommodative facility, the patient is failing minus, and the main stay is the monocular estimation method, the dynamic retinoscopy is lab. Okay, so in this way we can differentiate whether the patient is a case of convergent insufficiency, or whether the symptoms is because of convergent insufficiency, or whether any other underlying issues is making a patient a convergent insufficiency. Okay, so this is a case of pseudo convergent insufficiency. So the direct test here is low, but in indirect test it directs us towards the deficient in accommodation. So it's because of that the patient is having issues. Okay, so this is a case of pseudo convergence insufficiency. So again, next case scenario. Okay, so next case scenario. So a 12-year-old boy presented with a complaints of eye strain, burning, and watery eyes associated with reading. Problem began shortly after beginning of the school year. Could read about 15 minutes before experiencing discomfort, and also complained that after 15 reading 15 minutes, distance thing get blurred and takes several minutes to clear up. Okay, so all the problems seems to be worst towards the end of the day. All okay, systemic history, all okay. Okay. So now these are the finding that we have. Let's see what is the issues the patient is having. Okay, visual acuity is okay. Subjectively, the patient has only small significant refractive error, NPC 10 centimeter with accommodative target, but with PLRG 25 centimeter. Again, 10 exo, basin value, base out value, calculate AC value ratio, versions facility, NRA, PRA, accommodative amplitude, MEF, BAF, and MEM plano. Okay, so what would be the diagnosis of this patient? Okay, so what would be the diagnosis of this patient? Yeah, anybody can share? Okay, so let's check Fourier. Near exo, okay, greater than distance exo, NPC is receded, and basin value seems okay, and base out especially value for near is less, and the calculated AC by ratio is low. Okay, so NRA, PRA, these are the MEF, BAF values, and MEM is plano, means lead. Okay, so what would be the diagnosis of this patient? Anybody can share, or you can unmute yourself and discuss the cases if you have any confusion. Yeah, okay. I can find one answer. The convergence insufficiency. Okay, so yeah, convergence insufficiency. But any other thing that you can come up? Okay, apart from, yes, this is a case of convergence insufficiency. Okay, but one thing that is peculiar in these cases is, let's see. Okay, so I have a next slide to discuss. So just see, could read for 15 minutes before experiencing discomfort. Okay, also complained that after reading 15 minutes the distance thing starts getting blurred and takes several minutes before clearing up. Okay, so apart from our diagnostic test, also the peculiar complaint that the patient is providing to us is that the peculiar symptoms the patient is providing is that on doing consistent near work, he is seeing the distance thing blurred and taking several minutes to clear up. Okay, so yeah, of course the patient is a case of conversion insufficiency. Okay, but he also complains of blur when he looks at a chalkboard. Okay, he also complains of blur when he looks at the chalkboard, and distance vision is slightly reduced. And you can also see that the patient is low myopic, small myopic. Okay, so when all the data that probe patient's ability to relax accommodations are analyzed, accommodative excess is also present here. Okay, so although yes, the patient is a case of conversion insufficiency, but the symptoms and the taste, that again MAF BAF is also uh, poor. Okay, so this is a case, actually a case is a conversion insufficiency, but because with associated with secondary accommodative excess that had led to a patient become small myopic. Okay, so again the refractive status of the patient is small myopic. Okay, and all the our test relates to a patient with the convergent insufficiency, also because the patient complains that the distance thing gets blurred when doing near work and it takes time to clear up. Okay, so this gives us the idea that it is a convergent insufficiency with secondary accommodative access. Okay, so sometimes these things should also be related. Okay, so because of the high exophoria and reduced positive fusional versions and a negative near point of convergence, the patient is using high accommodative convergence to help maintain alignment, and this excessive use has led to a patient to accommodative excess. Okay, sometimes conversion insufficiency is associated with accommodative excess, and sometimes conversion insufficiency alone, and sometimes pseudo convergence insufficiency. So these all in these cases, okay, straightforward the cases of convergent insufficiency, but when we promptly see symptoms that the patient is complaining, we have to also look into that, whether what is the issues going on. Okay, so again, next cases that I have to share with you is that, okay, so what I'm doing is I'm sharing different varieties, how the patient might come with us, especially the particular symptoms that we have to keep in mind while managing the patient. Okay, so in that cases, this low, I'm not prescribed this low amount of refractive error present here. Okay, so apart, rather than that, we'd go for vision therapy and treat and monitor this refractive status, and of course after stabilizing the accommodative status of the patient, this refractive error would be uh, reduced, or we could eliminate this refractive error. Okay, so now next variation in conversion, again next variation. Okay, let's say a 18-year-old presented with the complaints of headache, eye strain, and blurred vision after 10 to 15 minutes of studying. Also complained of general eye discomfort in the evening and blurred vision when driving, particularly at night. Although he had problem reading throughout the high school, they were not never bothersome. He remember wearing reading glasses while he was in primary school, but discontinued and could not recall if they helped or not. Okay, so again let's see the finding of the patient. Visual acuity is 6 by 6. Okay, NPC 25 centimeter with PLRG 30 centimeter. Cover test distance to iso, near is to exo, and subjective the patient has plus 1.75 diopter refractive error. Basin base out value, versions facility fails base out, NRA plus 2.5, PRA minus 2.5, MAF 9 cm, and BAF 2 cycles per minute slow with 2 diopter. Okay, so MEM is lead. Okay, so here, okay, so the patient is exo for near and iso for distance, and the subjective finding is plus 1.75. Okay, yeah, this is a case of conversion insufficiency itself, because exo at near, okay, receded NPC and the base out value is poor. Okay, but this is the patient is hyperopic. Okay, so sometimes these kind of variations also we can found. Okay, it's not that the CI is not associated with any refractive error. Sometimes the hyperopic patients might also present us with the conditions of convergence insufficiency. Okay, so in that cases, what are the main key concept that we have to keep in mind is that is the patient's symptoms. Okay, you see, especially the general eye discomfort in the evening and blurred vision when driving. Okay, so we have to keep in mind whether the symptoms that the patient is having is because of the these convergent insufficiency that is present, or it's because of the uncorrected hyperopia. Okay, so or both. Okay, so is the patient symptoms is because of the hyperopia or the convergent insufficiency, or it is because of both. We have to rule out that. Okay, so in these cases what would be our management plan is that, so yeah, I'll ask all the participants, so what would be the management plan you see in this kind of cases, especially in consideration to the refractive error? So what refractive error would you prescribe, and what would be your treatment plan or concept that you would perform? Okay, so can anybody share what how would you approach these cases regarding management? Okay, so there is convergent insufficiency we can see, and the patient will also have a refractive error, especially the patient is hyperopic. So how would you approach these cases? Whether you would go for full refractive corrections, or you will not correct the patient and go for another approach in treatment, or what would you do? Can anybody share their views, or you can also unmute? Yeah, I can see one response: full corrections and VT. So any other VT plus lens. So first you'll perform VT and then you'll prescribe a refractive corrections. Yeah. So any other? Yeah. So what would my approach be is that, okay, so what is the main concern is that should we prescribe the hyperopia or not? Okay, so you see, if we prescribe that full amount of hyperopia in these cases, what would the plus lens do? The convergent insufficiency would become more manifest. Okay, so if we just treat CI, if we just one point to consider. Okay, so if we prescribe a hyperopia, full hyperopic prescriptions, if we prescribe, what would happen? It will make exophoria increase. It will increase the exophoria, and it would place a more demand on itself reduced post diffusional versions. Okay, so one take is that, and the next thing is, okay, let's neglect hyperopia. So if we treat CI, okay, so let's go to treat only CI. So would the patient will be comfortable because of that uncorrected hyperopia? So there are two take in these cases. Okay, so one is correct refractive corrections. If refractive correction is alone done, what would happen to the binocular dysfunction that the patient has? Again, if we neglect the refractive corrections that the patient has, what would happen to the uncorrected hyperopia? Because you see the patient is also complaining blurred vision and all. Okay, so what would my approach is, let's partially correct the patient. Okay, so let's partially correct the patient. Okay, so in that, in these cases, if I would approach these cases, or I would get these cases, or if this kind of cases comes with me, I'll go for partial corrections. Okay, I'll go for partial corrections of the patient, because the patient is also complaining blurred vision and all. So plus 1 or plus 0.75, you can make a partial corrections and do a VT, okay, and treat the dysfunctions. And then in a long run, we will go for full prescriptions of that hyperopia, okay, because with VT we could not decrease that all hyperopia. Okay, so first my approach would be, our approach is first partial corrections, okay, because this plus 1.75 is a significant refractive error, so we'll go for partial corrections in these cases, and then opt for VT, and then a full prescription. Okay, in a long run, after the convergent insufficiency is treated, we will, if after the positive fusional versions and that accommodative flexibility is improved, we will go for full prescriptions. Okay, so that should be the approach for convergence for any cases of convergent insufficiency that is associated with hyperopia. Okay, yeah, I see some of the questions. Okay, I'll just go with that because this is related to this case itself. So contact lens better or not? uh, I'll not go for contact lens corrections. Okay, so my aim is not to first fully prescribe the hyperopic glasses. Okay, because prescribing, so I'll not go for contact lens corrections in these cases. Should I perform fogging for patient? Yeah, we can perform a fogging for this patient. While prescribing every uh, hyperopic cases, but uh, if we do fogging and go with the maximum plus, that would not help this patient, because the full plus would increase or make the patients more uh, to work on positive fusional versions, because the PFV is again uh, reduced in this patient. So prescribing of full plus, what would happen? It will keep more demand on these poor positive fusional versions itself. Okay, yeah, fogging can be performed to determine the actual plus. Okay, but will not prescribe that amount of full plus. So again, what is the mainstay? Is the partial corrections, okay, and then followed by VT, and then in a long run, after the CI is treated, then we will go for full prescriptions for this patient. Okay, so that's how our approach would be. Now, in many, so in many in conditions now, or also the CI, especially what happens is, okay, so sometimes presbyopic patient, especially these things, we don't take much of considerations. Okay, so sometimes or most of the times convergence insufficiency in presbyopic patients also we find convergence insufficiency. Okay, so CI is actually the most common binocular vision problem in presbyopia and is often responsible for asthenopia. Okay, so unfortunately, problem that like these are ignored and left untreated in this population because of the misconception that VGT is not effective in adults. Okay, but the presbyopes with CI should be treated in the same way as presbyop, except the accommodative therapy. Okay, so if we have sometimes what happens is we encountered many of these cases actually in our practice. So adult, they are not comfortable with the glasses. If they are comfortable also, they have much issues while doing or near work for consistent period of time. Okay, so that kind of issues we find many of them in our clinical practice. So in that cases we should just uh, check whether the patient is having any binocular vision dysfunctions or not. It's not that these kind of issues are not treated in adult. Okay, so because the patient is presbyopic, we cannot work on accommodative therapy. We can make some improvement, but it's as it is a physiological reduction in amplitude of accommodation. But we can work on versions part, the positive fusional versions part, the NPC part. Okay, so um, CI sometimes is associated with presbyopia if the adult patient is complaining of some kind of a near walk issues, or they are having asthmatic symptoms with consistent near walk. we should also go for binocular. We should also go for binocular vision evaluations to check whether any dysfunction is present in them or not. Okay, so again, treatment is same. Uh, the but we basically omit the accommodative part in this patient. Okay, so we can we'll go up with the therapy part in the detail. Okay, so we can make the patient aware about the eyes is accommodating or relaxing, and basically we can work on especially the positive fusional versions through different tools to improvise their post-diffusional versions, so to reduce the symptoms that the patient. And sometimes, actually, we had a discussions earlier also. So in many times, because apart from vision therapy, a small amount of basin prism, okay, small amount of basin prism would be very much helpful in this adult patient. So now next case scenario. Okay. So let's see next case scenario. We see a 16-year-old girl, okay, in 11th grade, presented with a complaint of occasional double vision, intermittent double vision. The patient is having intermittent double vision, and the double vision was particularly bothersome when she had to take notes from board school and when driving. Okay. So again, we just need to understand the nature of the problem that the patient is having. The double vision is particularly bothersome when she has to take notes, especially and when driving. And her mother remembers about 4 years old. She was complaining also of double vision. At that time, doctor suggested the vision. It was okay. Okay. So general health is okay and general ocular health is okay. So visual acuity is six. Visual acuity is 6 by 6 or 20 by 20. NPC accommodative target 6 centimeter. PLR is also 6 centimeter. And on seeing cover test, the patient has 12 ISO for distance and 2 exo for near. And subjective +1. Basin value is poor and base out value is good, and the patient has low ACY ratio. NRA +2.5. PRA is this. MAF BAF okay, and the patient has normal lag of accommodation. So on seeing these finding, what would be your provisional diagnosis in this patient, and what would be the management of the patient? So anybody can share? Yeah, I can see one question. So would you consider base of your prism as well as prism to? I'll just answer this question in at last. Okay, after we'll finish this today's sessions. Okay, Sonia, we'll discuss this at the last. Okay, so about the Yoke prism. So yeah, so coming to this case, so what would be the provisional diagnosis that comes in your mind seeing the finding of this patient? Okay, so any other what would be the uh, diagnosis? So let's see the phoric status. So the patient is distance. The patient has greater amount of ESO. Okay, and near small exo. And so because the patient has ESO, let's see the negative fusional versions finding. So the negative fusional versions finding. So negative fusional versions is poor, very poor at distance. Okay. So this gives us the idea that the patient is a case of divergence insufficiency. Okay, so the patient is a case of divergence insufficiency, and also the low ACY ratio is there. Okay, yeah, I can see some answers on divergence insufficiency. Okay, so uh, each I can see also one of the participants Chungi convergence excess. Okay, so in case of convergence excess, what is if this would be a case of convergence excess? Okay, so the near ISO, if the near ISO was greater than the distance deviation, if the ISO was greater at near and the base in finding was poor, we would come to this case as a diagnosis of diverse convergence axis. Okay, so since you just see the distance iso is greater than the near. Okay, iso deviation is greater at distance, and the patient has low SY ratio. Okay, so this is not a case of convergence axis, although the Bayesian value is low. Okay, the Bayesian value is poor, but you can see the Bayesian value is good at near, but the distance Bayesian is very poor. So this is a case of divergence insufficiency. Okay, so what would be the treatment? Your treatment plan for this patient? Okay, of course I can see a response prism and VT. Yes, prism, as we discussed. Okay, the prism is a mainstay of initial treatment in the patient with divergence insufficiency. Okay, so coming to prism, there are many way of determining the amount of prism. Okay, so in the textbook we can see minimum prism criteria, associated Fourier criteria, dissociated Fourier criteria. Okay, under dissociated Fourier criteria we have Shear's criteria, Percival's criteria. So there are many criteria that has been hypothesized or that has been used, especially in the prescription of the prism, especially two conditions, the CI cases and in the divergent insufficiency cases. Okay, so the main most I just like to discuss something on the how to determine the amount of prism to prescribe. Okay, so basically the main thing that is discussed is the associated Fourier method, as it was not discussed more in the diagnostic part. Okay, the amount we determine the amount of fixation disparity, and based on that fixation disparity we'll prescribe the amount of prism. Okay, associated Fourier method. So what if you don't have tools to measure fixation disparity? Okay, so there is something called Shear's or Percival's criteria. So basically, in the case of divergence insufficiency, a Percival's criteria is used. Percival's criteria used, and it is used to determine the amount of required prism in the patient. Okay, so I guess you can go with the I guess you are aware about the Shears and Percival's criteria. Okay, Shears basically what especially that is used for the exo patient. Okay, so what is it? It says that the for efficient binocularity, for good binocularity for the patient to have the relative fusional vergence resolve, that is the base out to blur, should be twice as that of Fourier value. Okay, so what the Sears criteria says is that for efficient binocularity, the base out to blur value, okay, especially near base out to blur value, especially this is used in exo cases, should be double of Fourier value. Okay, so what is the thing is that if the patient has 6 exo for near, the patient should have, for efficient binocularity, the base out to blur should be 12. Okay, so that's a Sears criteria. So in this, the case of divergent insufficiency, basically Percival's criteria is used. Okay, so we can find a formula. There is a formula, or the Percival's criteria said that the target demand or the near demand should fall in the middle third of the fusional ranges for comfortable binocular vision to be there. Okay, so so in these cases, the main thing that we have to see is the Fourier value for near distance. Okay, because we are calculating a prism for distance, the Fourier value for distance, and this base in value. Okay, these two value is useful in calculating the amount of prism that is required for the patient. Again, the Fourier value and the distance negative fusional vergence value is helpful for calculating the amount of prism. What is a amount of prism useful for each individual cases? We can do that. If we have a fixation disparity instrument, we can use that and calculate the amount of fixation disparity, and divide that amount of fixation disparity in the two eyes and prescribe a prism. One method to prescribe is that Actually, that is the most utilized cases. But if we don't have an instrument to check a fixation disparity, there are another prism prescription criteria that is used, especially in the cases of divergent insufficiency, the ISO cases. Percival's criteria is used. Okay. So in these cases, we can see the patient is also a hyperopic. Okay, the patient is also hyperopic. So hyperopic prescriptions would be incorporated with a base out prism. Okay, hyperopic prescriptions would be incorporated with the base out prism and prescribed to the patient. Okay, so next case, a 10-year-old boy presented with a complaint of eye strain, blurred vision, and inability to concentrate when reading after 10 minutes. And their problems had been bothering him since the beginning of the school year, and the refraction was this. Okay, again, we can see distance Fourier 4 ISO, and the near Fourier is 2 ISO, and ACY calculated ACY ratio is 8 is to 1. Okay, NRA plus 2.5, PRA is 1. Okay, so what would be the provisional diagnosis of this patient based on this finding? So what would be the diagnosis of these patient based on the finding that we have? Okay. Yeah, this is a case of convergence excess. Okay, so we see the near Fourier is greater than that of distance Fourier. Okay, so this is a case of convergence excess. So yeah, in these cases, added lenses would be useful. Okay, so added lenses would be useful. Yeah, uh, or also we can go with the bifocal lenses. So if the patient or the child or the parent is not encouraged to use a near added lenses only, we can go for bifocals lenses also. It is a preferred choice. So now next cases, okay. So now next case, a 2-year-old child brought for eye examinations because of the concern about his left eye drifting outward. Although the mother has noticed since 2 to 3 years old, she felt it getting worse. In the past, the eye turned only when the child was tired at the end of the day. She felt that left eye was turning out. Okay, now let's see the finding. Visual acuity is 6 by 6, and NPC with accommodative target and PLRG is okay. And in cover test, the patient has the 20 intermittent left exotropia for distance and 5 is of exophoria for near. Okay, so subjective is 0.25, and the distance because of left intermittent exotropia, the base out and base in there is suppression, and near is this, and calculated ACY ratio is 12 is to 1. NRA is this, PRA is this, BAF and MEM is this. Okay, so what would be the provisional diagnosis of this cases? So yeah, this is a case with divergence excess. Okay. Also, we can see this is a case with divergence excess. Also, we can see that monocular amplitude of accommodative facility, monocular accommodative facility and binocular accommodative facility is also poor. Okay. So this is a case with divergence excess and with some accommodative infacility also. And because the refractive error is not such significant, vision therapy is the mainstay of treatment in these cases. Okay, so the overview of management is that the refractive corrections, significant refractive corrections, also if the presence of different binocular vision dysfunctions can change our concept of prescribing to the patient, so and deciding whether the added lenses is required or not, and prisms, and the vision therapy is the mainstay in the treatment. Okay. So regarding prisms, I can see some questions there. I like to go with the question first and then go with the uh, presentations. So how to measure fixation disparity? Okay, so there are different method of measuring the fixation disparity. Mallet unit, AO, vectographic slide. Okay, so we can measure it for distance also if the instrument is available. So how do we plot and analyze fixation disparity curves? Okay, actually it's a very vague thing. Fixation or graphical analysis is so so let's not go with that all the thing. Okay, so one thing, in the cases of divergent insufficiency, our main concern is what is the amount of prism to prescribe to the patient. Okay, so if you have a fixation disparity measurement tool, go with that. Okay, go with that. Measure the amount of fixation disparity that the patient has. Okay, if you don't have a tools to measure it at distance, you can also measure it at near or at intermediate distance, and then make a decision to prescribe the amount of prism. Okay, for example, let's see in these cases. Okay, actually with Percival's criteria, the amount of prism to prescribe is 6 prism diopter would come here. Okay, and then we'll divide that prism 3 base out would help in this patient. Okay, so fixation, if the fixation disparity you can measure, you just go with that. And then if it is not available, you can go with simply the Percival's criteria and decide the amount of prism to prescribe to the patient. Okay, so details of fixation disparity, actually we are not going. And yeah, one thing that Sonia has highlighted is the use of yoke prism. Okay, apart from going to some concept of vision therapy, I'm just trying to convey you some concept of yoke prism. I guess this yoke prism concept has been explained, some explained by Osmita ma'am also. Okay, so if the patient is the convergence excess, or the patient has divergent insufficiency, or the patient is convergence insufficiency, in uh, these cases a prescription of yoke prism. Okay, I guess Asmita ma'am will go detail into prescriptions of these kind of yoke prism, especially in the traumatic cases and in the special population. So in convergence excess, yeah, will prescribe some prescription of some amount of base down prism will be helpful. Okay, because it is tending to patient to high, the patient is conversing very much for near, so prescription of best down prism would bring that issues and would help in uh, tackling with that issues. Okay, and in the cases with other cases, okay, and in other cases the uh, in convergent insufficiency cases, the base up prism will help will help the patient in tackling with the deficient in conversion itself. So we can incorporate a prescription of yoke prism also. Okay, but if the patient is having simply having a non-strabismic binocular vision dysfunctions, so if that would also be one method of treating or making a adjustment in the prescriptions. But I'll not incorporate a prescription of these yoke prism, especially in if it is a solely a case of these non-strabismic binocular vision dysfunctions. Especially, I will go with that for the traumatic cases and especially the special population. Okay, and then VT. Okay, so now with all these thing, we'll go into the vision therapy part. Okay, so let's go. Some take points for VT is that okay. So after the refractive corrections, prescription of prism and all, and then the refractive corrections or the spectacle correction, and then we'll go for vision therapy part. Okay, so what are the some take points for vision therapy is that uh, actually many thing has been discussed initially also. So we have to determine at the level at which the patient can perform easily. What does it means? That the finding that the patient has is very important. Okay, and we should be aware about the frustration level. Okay, if the patient is at this level, will not take the do the activities at this level. Okay, so we should be aware of the frustration level, because it's about bringing the change in the visual system of the patient, and doing every activities use a positive reinforcement. Okay, so maintain an effective training level, that threshold or the threshold should be maintained, and emphasize to the patient that the change must occur within his or her own visual system. It's not that anything is coming outside and putting in the head. Okay, it's about the change in the visual system of the patient. Okay, and make the patient aware about the goals of vision therapy. So what is the, if the patient is convergence, what is a goal? Okay, so these initial discussions. Okay, so the initial discussions with the patient is very much important during performing the VT in all these aspects. Okay, and then set a realistic therapy objectives and maintain flexibility with these objectives and endpoint. Means it's not that if we are treating the patient with convergent insufficiency, for example, it's not that NPC should be at 6 centimeter or PFV at be the PFV at near should be that exact value. Some flexibility can be there, and we should use a VT tools that provide feedback to the patient. Okay, so what is a general principle is that, so first, making aware about the issues that the patient have with them, is a main concern that we need to know. Okay, and then we should discuss a nature of vision problem that the patient has, that is making a patient more problematic, and different feedback issues or the different feedback mechanism that is utilized, especially in performing VT activities. We have to make the patient aware of that. And the next thing that we have to make the patient aware is that it's not a one time thing. Okay, it's a matter of practicing the activities same day. We can go for we'll go for different activities. So practicing different activities, improving the visual efficiency, the skills of the patient. So that thing should be first discussed with the patient. Okay, again, we have to discuss the nature of the problem that the patient has, and what is our goal in doing the vision therapy, and what are the different what is the importance of doing this. It's not the one time job. We have to do it more and more. The more we do, the more efficient our visual skills will be. And after initiating the VT, the main first thing that we should make the patient aware is that the different feedback mechanism that the patient should be aware. Okay, so and then after these all initial thing, and then we'll go for the sets of activities. Okay, so today I'm just going to basically discuss some of the feedback mechanism that we utilize in vision therapy. Okay, the main thing, the one of the feedback mechanism is diplopia. Okay, so I had just discussed these sessions in this preliminary course also. I had a lecture there. Maybe some of the participants was discussing me and these after seeing this lecture also. So we'll talk about these feedback mechanism very much in the all the different activities. So I'm just going to quickly overview some of the feedback mechanism that we will utilize during our course of vision therapy activities. Okay, one is diplopia. So what does diplopia make the patient aware? If you are seeing anything double, it means that your eyes or your visual system is not making your both eyes align. Okay, the patient or the visual system is not making your both eyes aligned. You should make that eyes aligned. Okay, so this provide the patient that. Okay, and blur, if the patient is appreciating blur, what does it signifies? That the patient is over focusing or under focusing. So if the patient sees blur or blurring of some, let's say blurring of these targets. Okay, so this is tranaglyph. Blurring of these target, it signifies that the patient visual system is over focusing or under focusing. And suppression, Suppression means if the patient is, this is a traneglyph, we do it by using a red green glasses. If the patient only sees of one part, either red or green, it signifies that the patient both eyes is not working, only one eye is working. Okay. And luster, these luster aspect we discussed some in the sensory evaluation part. Okay. Perception of combination of color, when seen, when the patient is asked to fuse the target of different colors. So this is one of the feedback mechanism. What is the color that the patient is seeing? Either you are seeing red only or the patient is seeing green only. We will ask the patient what they are seeing, and on the basis of their response, we can make an idea that how the patient visual system or what they are seeing. Okay, so luster is also one of the feedback mechanism. It is a perception of combination of colors when seen. For example, I discussed in the sensory evaluation part a simple red lens placed in over one eye and the transil torch. Okay, the if the patient has good fusion, the target will appear pink. Okay, or the different color combinations can be seen. Okay, so it is also one of the feedback mechanisms. And the next feedback mechanism is kinesthetic awareness. Awareness means it is a awareness whether the patient is accommodating, conversing, or the accommodating, stimulating the accommodations, feeling of stimulating the accommodation, and feeling of relaxing the accommodations. Okay, these are the feedback mechanisms, especially this we utilize use in the versions as well as accommodation activities. And the next feedback mechanism is small in large out, is also called silo. Okay, silo. So we'll talk these in detail when we go with the therapy aspect. Okay, so what is silo is, what happens is, especially when we are conversing, when we are performing versions activities, and when we are conversing, and also utilizing the accommodations, the our perceptual system makes a correction with the change in the size. Okay, and it decrease the object size, and same happens when the we are performing a convergence as well as divergence. So this is one of the feedback mechanism that we utilize in the patient, in doing the activities with the patient. Okay, so and float. So if the patient is fusing these inner circles, the combination of red and green circles should be, is it something like it is floating in the space or not? Is it floating closer or farther away? This floating closer means the patient is converging, floating farther means the patient is diverging. Okay, so this is this feedback would help us to know what is the patient's visual system is doing while they are doing any activities. Okay, and the localization means pointing to any objects. And parallax means moving, when we move our postures, what is happening with the targets. Okay, what is happening with the targets, are they moving in the same directions or are they moving in the opposite directions? So these are some of the feedback mechanism that we explain to the patient while performing any of the therapy procedures. Okay, so what I discussed is, so before doing all the vision therapy activities, we have to just discuss with the patient about their aims. Okay, so what is a goals, what is a objective, what is a uh, importance of regular practice and doing every activities. We have to discuss what is a cue. Okay, so what is a cue that we can gain from the activities, or what is a cue that provides us an idea that what our visual system is doing. Okay, so these are the basic first initial discussions that we do with the patients before doing any vision therapy activities. And then there are different tools that we use in vision therapy, that is lenses, prisms. Okay, filters, occluders also, especially the lenses, prisms, and filters. So in upcoming sessions, we will have basically two sessions for the tools that are used in vision therapy. Okay, so that's some introductory part regarding how to go with the vision therapy aspect, how to proceed to our vision towards vision therapy after the glass corrections and added lenses and prism corrections to the patient. And then in the upcoming sessions, so in next sessions, 2 sessions, we'll have 2 sessions on the tools. Okay, so especially first sessions, basically we discussed about the lenses only, how the lenses would help, how they are utilized, what are the different mode of utilization of that lenses, especially from the vision therapy point of view. Okay, and then we'll go for prisms and filters. So that's all for today. Any questions that anyone wants to ask? Okay, so we'll be happy to answer. So I'll just scroll the chat box. Yeah, okay. So again, if the again different person can present with a different kind of issues. Okay, the mainstay is different person can come up with different kind of issues. So our role is to catch up what is the issues that is going with the patient. Okay, and then go uh, with the flow of management on different kind of conditions. Okay. So anybody has anything to ask? So one questions and that, yeah. Apart before going to that questions, okay, I like again regarding that prism. What is the amount of prism that we need to prescribe to the patient? Okay, so basically, I go for sears for especially if the patient is exo, and if I'll go for perceivals if the patient is ESO, and basically prism for convergent insufficiency will not utilize that much, but divergent insufficiency is the mainstay of treatment for the patient with prism is a mainstay of treatment for divergent insufficiency. For that, I'll basically utilize a perceivals. Okay, so I didn't discuss that formula part. Okay, we can basically get in a textbook. If anybody wants that part to be shared, I just shared that in the group itself. Okay, you can either find that 2 times Fourier minus compensating versions divided by 3, that is a formula for calculating the amount of prisms. I'll share that thing in the group itself. Okay, so basically, and then going with that amount of prism to prescribe, especially in the case of divergence insufficiency. So next question, one question again: when there is issues with those both versions and accommodation issues, is it always manage versions and then accommodations? Actually, it's not true. Okay, we have to. I just want to share with these your questions. I like to share this slide. Okay, as you can see in this slide itself. Okay, so you just see there were in this randomized clinical trial for the treatment of convergent insufficiency in the patient. So the treatment were divided into 3 phases. You just see what was the first phase: the development of gross convergence in the patient, the development of positive fusional convergence, and also accommodative therapy. And in the second phase, ramp means increase the range of, okay, increase the range, and then again accommodative therapy. So it's not that the versions should be first and accommodative should be second. We have to take both aspect at the same time. Okay, so also first develop gross. If it is gross convergence, if we need to develop gross divergence, then again increase the sensation of divergence and negative fusional convergence, and also work on accommodations. If we only work on vergence, okay, and left the accommodative part, the will not be able to improve the status of the patient. Okay, because we know that how dominant is the accommodations in our visual system. So both part should be taken into consideration. So parallel or hand in hand. Okay. So one next thing I can see is why our visual system keeps changing. As is it possible to uh, why our visual system keeps changing? Is it possible to go from convergent insufficiency to convergence excess? Yeah, actually, these are all the adaptations to visual stress. Okay, so these are all the non-strabismic binocular vision dysfunctions that are considered to as an adaptation to visual stress. It's because of that visual stress that is causing all these dysfunctions, and some of them are adaptations. Okay, convergent insufficiency is also one of the adaptations. Convergent insufficiency is also one of the adaptations. So depending upon, actually each visual system is different. Okay, each of our homeostasis mechanism, our all these mechanism, stress resistance mechanism is different. So we may suffer from different kind of these non-strabismic binocular vision dysfunctions. Okay, so, Chongi, are you asking, is it possible to converge? Is it possible to change from convergent insufficiency to convergence excess? Are you trying to ask that? Okay, if you are going to ask that, yeah, actually what could happen is that, okay, so you perform a VT. Okay, you completely treat a patient with convergent insufficiency and you bring back all the findings to normal. Okay, after making a patient stable again, if the maintenance therapy is not done, or if the patient has lots of near works to do, the visual system may adapt into other changes also. It's not that it will happen, but it might happen. Okay, it's not that it would happen, but after treating and if the again it's not that the convergent insufficiency will evolve again, but the visual system might go into some change, but we cannot say how it goes. Okay, so it's not predictable. Next question I can say is, sir, what is prism adaptation? Can we assess this before prescribing prism? Actually, is there prism adaptation in divergent insufficiency? Especially prism adaptation is a issue, especially in convergent insufficiency. Okay. So why in convergent insufficiency is that in convergent insufficiency we prescribe a basin prism. Okay. Basin prism will actually relax the accommodations, but we actually accommodate at near and we exert more amount of accommodative convergence at near. So prism adaptation is of more issues, especially in the case of convergent insufficiency. But in divergent insufficiency, especially the prism is prescribed for distance. Okay, so the main stay to reduce symptoms or the signs is at distance for the case of divergent insufficiency. So there is less chance of prism adaptation. Okay, but especially in children, okay, their visual system is so flexible, or the accommodative convergence will work very dominantly that they will start eating up of the prism. So basically basin prism, as we can see, especially the randomized clinical trial also. So especially if it is a children, I'll not go for prescribing a prism. But if the adult, especially as we discussed, is if CI is associated with adults, if the prescription of some basin prism would help, I'll prescribe to that patient. Okay, so because again in case of divergent insufficiency, especially the prism is for distance uh, point. Okay, so the less chance of prism adaptation. So yeah, Asmita ma'am, you want to share anything?
No, that mistakenly happened. That raising hand. I'm sorry.
Yeah, you want to share anything? Yeah, so the actually everything, each and every symptom, signs, findings, the treatment part, the evaluation part, everything is that particularly correlated that. So any change in sequence or any change in specific finding would particularly take us to the another point of treatment, diagnosis, and another point of management. So a concrete concept regarding all this, especially from the history part and the evaluation part, and what is the management plan, that is very important for us. Okay. So do we do VT for intermittent or alternating trope? Yeah, yeah. Actually, we do that. Okay, I think that will be discussed, especially in the strabismus part. But we do that. Okay. So again, evaluating the patient, what is the issues the patient, and improving that visual skills to take that into normal. Is there any cases in which we can think of minus? Yeah, especially in the case of divergence excess, it is advocated that minus added lenses would be helpful, but I'll not go with that. Okay, I don't. There are there are textbook advocating the use of minus added lens, especially in the divergence excess cases. But I'll go for VT itself rather than minus addition lenses. Okay, because it would be temporary, and that how we have to evaluate all the ACY ratio. Yeah, initially some minus lenses could be added, but I'll not consider prescribing a minus added lenses to a case of divergence insufficiency cases.
Okay, I guess we have answered almost all the questions till now. And considering the time limits, here I announce the closure of the discussion session. And we can also have the further discussions on our
Come that
WhatsApp
side. Come that
group
side.
too.
So yeah, in the next
So
sessions
I
we'll
would like to
discuss on the tools. Solo, I just want to add a last thing here. So in the next sessions we'll go with the tools that basically we utilize in the vision therapy. Okay.
Okay. I would like to express my immense gratitude towards our faculty, Hira sir, for sharing his invaluable insights, and to all the attendees for their endurance. Herewith, I announce the closure of today's session, hoping to see you all again in the next session. Stay safe, stay connected. Thank you.